Hello, everyone, and welcome to our question lab. We're happy to have you here as we discuss cardiac pathology. Leading our session this evening, once again, is Dr. Paras Vicaria, and he is going to introduce himself now.
Hey guys, my name is Paras. I'm a dermatology resident at UT Southwestern here in Dallas, Texas. I originally graduated from pharmacy school in St. Louis, Missouri, and then went back home to Michigan to do medical school. And I'm also working as an RX coach with USMLE-Rx. So basically helping to work one-on-one with students to help prepare them for the USMLE Step 1 and the Step 2 CK as well. And I'm happy to lead tonight's session.
Excellent. Helping us out tonight as we discuss cardiac pathology are a couple other panelists. We have Alec Kellish, one of our RX coaches. He's going to introduce himself now.
Hey everyone, my name's Alec. I am a fourth-year medical student at Cooper Medical School in Camden, New Jersey. I matched into orthopedic surgery at Thomas Jefferson in Philly. I've been with RX now for about 9 months. I used it as a student and have been really happy to work with the company. And I look forward to answering all your guys' questions tonight.
Excellent, and we're happy to have you here. We also have Jeff, who you'll meet later. If you look at your GoToWebinar control panel, you will see a question box. You're welcome to type your questions in there, and our panelists will do their very best to try to answer all of your questions for you. My name is Sean. I've been with RX Coach for over 2 years now, working with our coaches and students to help them accomplish their academic goals. We have conducted over 1,500 sessions and helped over 300 students. So we've got a great track record and some great success stories, and we'll talk more about RX Coach a little bit later this evening. I know I mentioned RX Coach earlier. We're going to talk more about that later, but I will say right now that what we're going to do today with all 4 questions on cardiac pathology is use the same process and methodology that we use in RX Coach. It's a little bit different because there's over 100 of you here tonight, but you'll see what we do in our coaching sessions. And so we're going to go ahead and get into our first question of the evening. And as you can see, the answer choices they have been removed, and that is by design. We do that because we don't want our students to be distracted by the answer choices or have their thought process be dictated by those answer choices. And especially, we don't want you to see an answer choice that you are unfamiliar with that may cause you to panic as you're trying to read that question. So once we've removed or covered up those answer choices, we will go ahead and move on to the lead-in. The lead-in is the last sentence or the question itself. Which of the following vascular findings is associated with this patient's most likely condition? Which of the following vascular findings is associated with this patient's most likely condition? After that, we'd like to ask our students how many steps they believe this question will require. An example of a one-step question could be where they ask you what is the diagnosis. An example of a two-step question could be where you're asked for the treatment for a diagnosis. And an example of a 3-step question is when you're asked for the mechanism of action for a treatment for a diagnosis. So with those examples in mind, please let us know in the question box how many steps you think this question will require. I see one of our new coaching students was the first to respond. All right, let's go ahead and read that vignette. A 66-year-old man presents for his annual examination. His history is significant for a 45-pack year smoking history. Physical examination reveals a pulsating midline abdominal mass. Which of the following vascular findings is associated with this patient's most likely condition? I want to give all of you a moment to start thinking about the relevant clues in this vignette as I hand it off to Paras. Paras.
Thank you, Sean. So we're going to go ahead and show you what we think are the important clues in this vignette and the lead-in. And starting off with the vignette are the demographics. So, whenever they give you demographics, it's usually the first thing in the vignette, and it'll automatically start to clue you into certain things and maybe make you think less of other things. So it's always important to make note of those demographics. And as you can see here, this is kind of a little bit of a shorter clinical vignette. And maybe that's the trend that we'll be going. And we'll kind of see a little bit here about his smoking history, and then they just give us one physical exam finding. So that's obviously going to be important. Now, the lead-in is asking us specifically a vascular finding associated with the most likely condition. So how many steps is this question? Well, one, I think we need to figure out what this patient's condition is. And then 2, what could be associated with that condition? What kind of vascular finding could be associated with that condition? So maybe a 2-step question here. So let's go ahead and take a look at those answer choices. And what we see are 5 answer choices here. And what I'm going to do is I'm actually going to go ahead and read them out loud one by one. And I'm going to start at the bottom and work my way up to the top. And the reason we recommend this is because sometimes we'll see students who, they'll start at the top, they'll see something they like, they'll select it without having gone through all the answer choices. And then sometimes they'll get that question wrong. So we recommend starting from the bottom up to ensure you don't do this and you don't bias yourself. So we'll go ahead and do that now. Answer choice E, ischemic bowel necrosis. D, granulomatous aortitis. C, blood vessel intimal tear. B, atherosclerosis. And A, arterial cystic medial degeneration. So we're going to go ahead and open up the poll. Go ahead and select the vascular finding that you think is associated with this patient's condition, most likely condition, and we'll talk about it in just a few seconds.
Excellent. Thank you, Paris. So the poll is open. Once again, we're going to wait until about 2/3 of you have responded. And then as always, Paris will go over the correct and incorrect answer choices. Remember that as you're doing questions, it's important to not only look at the correct answer, but also to review the incorrect answers, as that will help you maximize your benefit from each practice question that you do. We'll give all of you a few more seconds here. All right, let's take a look and see what all of you selected. Looks like we have a clear favorite, and that's atherosclerosis, with 52% of you choosing that answer. In second place, we have blood vessel intimal tear. So let's see what the correct answer is. And the correct answer is indeed B, and 52% of you got it right. So we're off to a great start. Let me hand it off to Paris.
Thank you, Sean. Great job, guys. So this is answer choice B. So way to go. So let's take a look at this question again. So this guy has a pulsating midline abdominal mass and a 45-pack year smoking history. Notice those are the 2 things that we highlighted in the vignette, and that's really, with that in the demographics are really all you need to come up with the diagnosis. And this really should be cluing you in to an abdominal aortic aneurysm, or AAA, okay? A lot of them are asymptomatic and are, just detected inadvertently during a study, a radiologic study, which is maybe what happened here. So there are some certain risk factors. There's smoking, older age, male sex, family history, okay? And actually on the next slide, Sean has gone ahead and pulled up a table on aortic aneurysms, okay? And specifically looking at that row of abdominal aortic aneurysm. As you can see there, it's usually associated with atherosclerosis. Risk factors include history of tobacco use, like our patient, increased age, our patient was 66, and male sex as well, like our patient. May present as a palpable pulsatile abdominal mass, which is how our patient presented as well. So all things that are pointing to an abdominal aortic aneurysm. So hopefully you guys were able to pick up on that, okay? Now, if you look on that row below that, you can see a thoracic aortic aneurysm is associated with cystic medial degeneration, which is maybe what some of you selected as well. But that's a little bit higher up, obviously, and associated with other things, other risk factors. This is specifically getting at an abdominal aortic aneurysm. So let's go ahead and take a look back at our vignette. And obviously you can see that the physical exam says that pulsating mass is abdominal as well. So that really should be cluing you in to an abdominal aortic aneurysm. Let's take a look at the other answer choices and why those are maybe incorrect. Ischemic bowel necrosis. So that can present with abdominal pain. It's usually sudden severe abdominal pain, but that's not exactly what we're being told in this clinical vignette. Granulomatous aortitis, that could be getting at a couple things, such as Takayasu's arteritis and other large vessel granulomatous vasculitides as well. Patients present with fever, weight loss, weak pulse, claudication in the legs. and we're not really seeing that as well. Blood vessel intimal tear, which I believe was the second most highly selected answer. So this is something that you commonly can see in aortic dissection. However, signs and symptoms of that would be a crushing pain, radiation to the back, difference in blood pressure between the left and right extremities. And again, we're not given any of those information. And then lastly, answer choice A, we talked about this. This would be getting at more of a thoracic aortic aneurysm. So the best answer choice here is answer choice B.
Excellent. Thank you, Paras. Great job, everyone. We are off to a strong start. Let's keep the momentum going as we move on to our second question of the evening. Once again, the answer choices are covered up. That is by design. We do that to make sure that the answer choices don't guide or dictate your thought process, and so that you don't see an answer choice that you're unfamiliar with, which causes you to panic as you're trying to answer the question. We then have our next step is to read the lead-in or the last sentence or the question itself. And we do that because we want you to know what the test writer is asking. This way, as you're reading the vignette, you can pick up on all those relevant clues without having to reread that vignette and waste time. So let's read that lead in now. Which of the following is most likely responsible for this patient's clinical findings? Once we read the lead in, we'd like to ask our students how many steps they believe this question will require. So I'll give all of you a few moments here to let us know in the question box how many steps you think this question will require. All right, let's go ahead and read that vignette. A 72-year-old woman presents to the office because of 2 months of increasing shortness of breath on exertion. She denies chest pain or a history of hypertension. Her history is significant for long-standing rheumatoid arthritis, for which she takes methotrexate and ibuprofen. Blood pressure is 118/72, and oxygen saturation is 91% on room air. Auscultation reveals a prominent S4 sound and pulmonary bibasilar crackles. Jugular venous pressure is 10 centimeters. Lower extremities show 2+ pitting edema. Left ventricular ejection fraction is 60% on echocardiogram. ECG shows diffusely decreased QRS. Which following is most likely responsible for this patient's clinical findings? I want all of you to start thinking about the relevant clues in this vignette as I hand it off to Paras.
Thank you, Sean. So once again, we are going to go ahead and show you what we think are the important clues in this vignette and the lead-in. So as you can see here, this is a significantly longer clinical vignette, and there were a lot of important findings as Sean read off that question. So again, demographics. We were told about a 72-year-old woman. Usually they tell you why they came to the ER, why they came to the office, and here it's specifically increasing shortness of breath, but specifically on exertion. So that's always important. Is it at rest or is it on exertion? And then also, how long have these symptoms been going on for? In this case, 2 months. So it's important to make note of that. Is it acute? Is it chronic? And that time frame really helpful. We're given some past medical history, some medication history. We're given some vitals, some abnormal physical exam findings as well. And all of these are important. And as we know, we're doing cardiac pathology, so it's important to take note of these, especially the ones that are abnormal, but also ones that can be helpful as well. So then they give us some echo findings, EKG findings, and obviously we're going to have to use some of that knowledge about those exams to really help us figure out what's going on in this question and also do well on step 1 when it comes to cardiac pathology. So then we go to the lead-in, and it's asking for what's most likely responsible for the clinical findings. Well, I think in terms of how many steps is this question, I think 1, we need to figure out what's going on in this patient. What are these clinical findings getting at? And then 2, that could maybe be like what's causing it, maybe the pathophysiology, what's the true culprit here. So I think we could have a two-step question going on here. So maybe three depending on the answer choices, but at least 2 steps here. So let's take a look at those answer choices and see if what we're working with. So we have 5 answer choices here, and once again, I'm going to go ahead and start at the bottom and work my way up. So answer choice E, myxomatous degeneration of mitral valve leaflets. D, ischemic heart disease. C, extracellular amyloid deposition. B, dilated cardiomyopathy. A, concentric left ventricular hypertrophy. So once again, we're going to go ahead and open up that poll and then go ahead and select what you think is most likely responsible for this patient's clinical findings. And we'll talk about it in just a few seconds.
Wonderful. We'll give all of you a few seconds here to submit your responses. In the meantime, I'm seeing a lot of questions about step 1 changing from pass-fail and to pass-fail rather, and whether you should take your exam now or wait. At the end of the day, if step 1 is pass-fail, the step 2 score is still going to be a 3-digit score, and that's what's gonna be looked at, right? But the best way to do well on step 2 is to do well on step 1. So there really are no shortcuts. If you can get a score and make yourself more competitive by doing well, we recommend that. But remember, just because it's pass-fail doesn't mean you should cut corners, because a lot of that step 1 information is going to be important for you to know and master as you study and try to conquer step 2. And of course, if you do take your score while it's 3-digit and then it changes to pass-fail, that 3-digit score will still be reported. If you want more information, you can go to usmle.org/announcements. All right, let's take a look and see what you selected. It was close, but in first place, we have concentric left ventricular hypertrophy. So let's see what the correct answer is. And the correct answer is C, extracellular amyloid deposition, and 22% of you selected that. So a challenging question indeed. But if you're getting these questions wrong this evening, don't worry about it, because we're here to learn. And if you listen to Paris, you'll be able to get it right on test day. So here we go, Paris.
Thank you, Sean. Yeah, definitely a tough question here. So let's take a look at this vignette again. We have an elderly woman, and we know she has a long-standing history of rheumatoid arthritis, a chronic inflammatory disease, okay? She's got lower extremity edema, she's got jugular venous distension, and she's got crackles in her lungs. So that suggests that she has congestive heart failure, okay? Now, they also tell us that her EF is pretty good, it's 60%. And she also has an S4 heart sound. So we really should be thinking about diastolic heart failure. So we talked about why we think she has congestive heart failure, and then we're using those additional clues in the vignette to point us towards diastolic heart failure. So diastolic heart failure can be due to a few things. It can be due to hypertension. It can be due to valvular disease, hypertrophic cardiomyopathy. However, what they're giving us is they're giving us an EKG that's showing diffusely decreased QRS complexes. So that should really point you towards something infiltrating into the myocardium. And an example of that would be restrictive cardiomyopathy. So the myocardial tissue is being replaced with something else, something that's less contractile, less distensible, okay? So now we've gone into the restrictive cardiomyopathy pathway, okay? And on the next slide, Sean has actually gone ahead and pulled up a table of our restrictive cardiomyopathies, okay? Now, it can be caused by a few things. It can be caused by fibrosis, such as that from scleroderma. It can be caused by infiltrative causes like we just talked about, so amyloidosis, sarcoidosis. It can be storage diseases such as hemochromatosis or glycogen storage disorders, and then a few other causes there as well. Now, the only thing we really know is that this patient has rheumatoid arthritis, okay, which is, as we said, a chronic inflammatory disease. So we really should be thinking about secondary amyloidosis, okay? Cardiac amyloidosis is, I believe, the most common form of restrictive cardiomyopathy in the United States, and it can occur specifically in those patients with a chronic inflammatory disease, such as rheumatoid arthritis. And the reason is because you get that SAA, or serum amyloid A protein, that gets deposited and is elevated in states of chronic inflammation like rheumatoid arthritis and other states as well. So backing up, this is a patient we determined had heart failure. We then determined had diastolic heart failure using those additional findings, and then we determined had restrictive cardiomyopathy. So within our restrictive cardiomyopathy, we then needed to use her history of rheumatoid arthritis to determine that this was probably an inflammatory or a serum amyloid A type amyloidosis. And actually, in a couple slides further, I believe there's actually a further table in first aid on specific restrictive cardiomyopathies. So there's a nice mnemonic there that can really help you remember some of those causes of restrictive, specifically infiltrative cardiomyopathies. Okay, and you can see there amyloid is one of them. Okay, so going back to our question and looking at the other answer choices, why are those incorrect? Well, answer choice E, that's getting at something like mitral valve prolapse that can lead to mitral regurgitation and then maybe heart failure. But this patient would then present with the systolic murmur and an S3 sound, and so not really what's going on in this patient. Ischemic heart disease, answer choice D, such as in patients with repeated heart attacks or myocardial infarctions, that would be more associated with the dilated scarred ventricle and systolic dysfunction, which is not what we have going on here. We have dilated issues. Answer choice B, diastolic issues. Answer choice B, dilated cardiomyopathy. This can be caused by a variety of conditions such as excessive alcohol intake, myocarditis, ischemic heart disease, but you really should be hearing more of an S3 sound rather than an S4 sound. And patients would usually also have a reduced ejection fraction. Our patient's EF was actually pretty good. And lastly, answer choice A, concentric LVH. This is something that you can see in a few things, and it can lead to diastolic heart failure, usually in the setting of hypertension. Other causes include aortic stenosis, but chronic hypertension is the most common cause. But you can see there, our patient's blood pressure is actually pretty good, 118/72. So probably not hypertension causing diastolic heart failure. So this is a tough question, but answer choice C is probably the best answer here.
Excellent. Well, great job, everyone. I know that was a challenging question, but you are going to have challenging questions on test day, so it's good to learn how to deal with them and how to approach them. And if you need help approaching them, we're here to help you. So, a little over 2 years ago, we launched RX Coach, and RX Coach is our tutoring and coaching program. And, if you're sitting there, you're thinking, I should have gotten that right, but I didn't. That might be a test taking issue. If you know you need help with test taking skills, we're here for you. If you want help making a study schedule or a study plan, we're here for that as well. So the first thing we do is we administer an assessment, and then based on that assessment, what we do is we create a personalized study plan. And then we work with you to implement that study plan at regular intervals. So your tutor may say, okay, this week we want you to study this subject and do X, Y, and Z. Once you finish doing that, you'll actually meet with your tutor to go over that topic. You'll have concepts explained to you, be able to ask your tutor any questions you have, and then actually do practice questions on that topic together. Now, unlike tonight, what's important in this question? What do you want to highlight? What are you thinking? And by asking all those questions, we're really able to see and diagnose what your areas of strengths and weaknesses are so that we can help you. And in that process, we also get to know how you think and apply what you know, so we can help you answer these multiple choice questions and help you, maximize your potential on test day. Especially for international medical students, sometimes the knowledge base is strong, but being able to answer those questions, that's a little bit more challenging because, a lot of IMGs aren't exposed that much to doing multiple choice questions. And we've had a lot of success with our program on all fronts. So if you're interested in receiving the help of an experienced coach like Boris or Alec and having somebody guide you through the process because they have been through it and they are where you want to be eventually, reach out to us at rx-coach or rx-coach.com. Click on that free consultation tab. Now, the free consultation is to discuss the tutoring program and how it can benefit you. And so if you're interested in learning more about it, you can visit us online at rx-coach.com. Now, many of you may be considering working with a coach or a tutor. Keep in mind that no matter what you do, no matter what service you pay for, you want to have somebody that has experience, and ours is unparalleled, right? We've been around for 30 years in medical education. We were in medical education before we started tutoring. Our founders authored First Aid. They authored RX 360 Plus, which includes BRICS, QMAX, First Aid, as well as Flashbacks. And you'll have access to all of those digital resources with every package that you sign up for. So once again, that's rx-coach.com, and you can visit us online and schedule that free consultation if you want to learn more about the program. Okay, we work with students not only for step 1 and step 2, but also while they're in medical school and for the COMLEX as well. All right. So with that, let's go ahead and move on to our third question of the evening. Keep in mind that, as always, there is a raffle at the end, and you must be present to win. We'll go ahead and begin with the lead-in. If the patient is not treated, which of the following complications is most likely to occur in the next month? If the patient is not treated, which of the following complications is most likely to occur in the next month? And then I'll give all of you a few seconds here to let us know in the question box how many steps you think this question will require. All right, let's go ahead and take a look at that vignette. A 24-year-old man presents to the clinic with 3 days of fever, night sweats, and fatigue. He has become short of breath in the past day. He uses injectable drugs. Temperature is 39.4 degrees Celsius or 103 Fahrenheit, and oxygen saturation is 88% on room air. Physical examination reveals jugular venous distension and a new holosystolic murmur, best heard at the apex. Skin examination reveals 1 to 2 millimeter red-purple spots on both legs. If the patient is not treated, which of the following complications is most likely to occur in the next month? Once again, I want all of you to start thinking about the relevant clues as I hand it off to Paris.
Thank you, Sean. So once again, we're going to go ahead and show you what we think are the important clues in this vignette in the lead-in. And we actually have a younger patient in this case, a 24-year-old man. Why is he coming to our clinic? Well, he's got fever, night sweats, and fatigue. They also tell us that the duration has been 3 days. So hopefully you guys are picking up that the duration and symptoms are important to make note of. Okay. They also say he's been short of breath in the past day. He's been using injectable drugs. He has a fever, some other abnormal vital signs, and some physical exam findings. Obviously important to make note of that and process it and try to think of what may be going on. And then as always, some nice skin findings there as well, which I love to see. So what is this question asking us? Well, this question is saying, if patient's not treated, which complications most likely to occur in the next month? So there's an additional layer there as well. So how many steps is this question? Well, 1, I think we need to figure out what's going on with this patient. 2, what complications could arise if the patient's not treated. And then maybe 3, figure out most likely to occur in the next month. So they added that extra wrinkle there, so it's important to make note of that and highlight that, okay? So at least 2 steps, maybe 3 months if we're taking that time frame into consideration as well. So let's go ahead and take a look at those answer choices. And we see answer choice E, ventricular hypertrophy, D, stroke, C, pyelonephritis, B, pulmonary embolus, and A, impetigo. So once again, we're going to go ahead and open up that answer poll. Go ahead and select the complication you think that's most likely to occur in the next month if this patient is not treated. And we'll talk about it in just a few seconds.
Excellent. Thank you very much, Paris. Once again, we'll wait until about 2/3 of you have responded. I see a lot of questions still about step 1 and step 2 going pass fail, and some thoughts on whether step 2 is also going to go pass fail. And there's really no way to game the system. Okay, I mean, Your goal at the end of the day is not to pass the boards. Your goal is to become a good physician. In order for you to do that, you need to master the material on step 1 and on step 2. So your best thing to do is study as hard as you can, do as well as you can, take your assessments, and take those exams as soon as you're ready, aiming for the highest score possible and the most amount of questions correct, even if it's pass-fail. For now, step 1 is going pass-fail, but there are no reports of step 2 going pass-fail as of yet, okay? We'll give all of you a few more seconds here, then we'll go over the correct and incorrect answers. Let's go ahead and take a look and see what all of you selected. It looks like in 42% was pulmonary embolus, and that was a clear favorite. So let's go ahead and take a look and see what the correct answer is. It's actually D, stroke. Okay, so that was our second most commonly selected answer. We'll have Paris explain to us why it is in fact the correct answer and why the other ones are incorrect now. Paris.
Thank you, Sean. So definitely a tough question. So let's see what's going on here. So this patient has a fever, has fatigue, and they told us has a heart murmur, okay? So let's take a look at that vignette and we'll see exactly what kind of clues they're giving us about that murmur, okay? So we could see there that it is a holosystolic murmur best heard at the apex, okay? So we do also know that this patient is an injectable drug user. So we really should be thinking about infective endocarditis, which is maybe what a lot of you guys were thinking, okay? No, it can either be due to right-sided valve lesions or left-sided valve lesions, okay? However, they're telling us that this murmur is a holosystolic murmur best heard at the apex. So that is characteristic of mitral regurgitation, okay? Mitral regurg causes a holosystolic murmur best heard near the apex, okay? Now, infective endocarditis can also cause some skin findings. We know splinter hemorrhages are one. There are Janeway lesions and Osler's nodes, which we'll talk about in a second, and then Roth spots as well. So those multiple spots on the legs are probably petechiae or even splinter hemorrhages if they're on the nails, okay? So what is a complication from this? Well, emboli from infective endocarditis are different on the right side and left side. So we've determined now that this is probably a mitral regurgitation, so a left-sided emboli, okay, as in this patient. So that emboli from the left side can go and get lodged in the brain and maybe cause a stroke, okay? They can also cause other issues, maybe going to the kidney, the gut, other organs, okay? Now, if this were right-sided infective endocarditis, then sure, we could be talking about emboli going to the lungs and maybe causing a pulmonary embolism, okay? And maybe we were suspecting that because, you know, intravenous drug use most commonly is on the right side, right-sided valves, but keep in mind that they did give us a physical examination clue about where the murmur was best heard, okay? On the next slide, Sean has actually gone ahead and pulled up the table from first aid looking at bacterial endocarditis, okay? Now, you can see there are some of those signs and symptoms that our patient maybe had, okay? So fever, a new murmur, okay? Always keep in mind the cutaneous manifestations such as Osler's nodes, Janeway lesions, splinter hemorrhages, okay? And then keep in mind where exactly are they giving us physical exam findings that point to which valve is actually involved. Is it an echo finding? Is it a murmur that you heard? And in this case, if we go back to the vignette, you can see that it was holosystolic, best heard in the apex, which is the mitral area, okay? So a little bit of a tricky question. Let's look at the other answer choices, maybe why those are incorrect. Ventricular hypertrophy. You know, if you have valvular disease, that can cause ventricular hypertrophy, but that's more of a chronic long-term issue, not something you would see in the next month, okay? Pyelonephritis, that is a complicated upper UTI or urinary tract infection, and that's not what's going on here. It's a little bit of a one you can cross off. B, pulmonary embolism. I understand why a lot of people selected this, probably thinking right-sided valve disease and then sending a little emboli to the pulmonary vasculature. But as we talked about, this is a left-sided valve disease issue. And then lastly, impetigo. Impetigo is a superficial skin infection, usually due to staph or strep pyogenes, and it's not a complication of what this patient has. So the best answer here is D, and it really came down to using our clues to figure out that this was left-sided instead of right-sided endocarditis.
Excellent. Well, thank you so much, Boris. Yeah, a couple of tough questions this evening. You know, if you're struggling with these questions, don't hesitate to reach out to us at rx-coach.com. You know, it's not we're not here just to help those who are struggling. We're here to help you do better than you're already doing. So once again, that's rx-coach.com. Now let's go ahead and get into our last question of the evening on cardiac pathology. For those of you asking, next week's topic is neurology. And as always, we do have a special offer and a raffle for all of you in attendance. So make sure you stick around until the end. Let's go ahead and begin with that lead-in. Which of the following most likely caused the patient's condition? I'll give all of you a few moments here to let us know in the question box, which seems very active today, how many steps you believe this question will require. I see one of our students saying this is really helpful so far. Thank you for the compliment. Let's go ahead and read that vignette. A 45-year-old woman with infertility presents to the clinic because of substernal chest pain when climbing stairs, relieved with rest. Physical examination reveals short stature, 142 centimeters or 4 feet 8 inches, and low set ears. A 3/6 mid-systolic blowing murmur is heard at the right upper sternal border, and her pulse is delayed. Which of the following most likely caused the patient's condition? Now, I see a lot of you jumping ahead to the answer choice in the chat box. Remember, it's not a competition. Let's take our time and make sure we get it right. I'm going to hand it over to Paris.
Thank you, Sean. So once again, we're going to show you what we think are the important clues in the vignette and the lead-in. And you know, this is our fourth time doing this, so hopefully you're starting to pick up what we think are relevant clues and maybe what doesn't need to be highlighted, so that when you go back and look at this question, really the important stuff that you highlighted is really all you need to know, like that question with the smoking history and pulsatile abdominal midline mass. That's really all you needed in that question. So this is hopefully this is a good practice for you guys as well. So we'll go ahead and do it with this question as well. Again, demographics. A 45-year-old woman, they tell us that she has infertility. Whenever they give you something right off the bat like that, always important to take note of it. They give us some other symptoms and signs of why she came to the clinic. Always important to make note of that. We get some interesting physical exam findings, obviously some cardiac findings since this is our cardiac pathology session, and then a delayed pulse. So what's most likely causing the patient's condition? Well, I think one, we need to figure out what is going on with this patient. Maybe what is a diagnosis? And then two, what is causing it? Maybe that's getting at pathophysiology, maybe something else. So probably a two-step question here. So let's go ahead and take a look at those answer choices. And once again, we're going to start our way at the bottom and work our way to the top. And hopefully this practice is really setting in with you guys as well, and you guys are able to pick up on this as well. So let's take a look at those answer choices. Answer choice E, narrowed coronary arteries. D, coarctation of the aorta. C, bicuspid aortic valve. B, atrioventricular septal defect. And A, rocker bottom feet. So go ahead and select what you think most likely caused this patient's condition, and we'll talk about it in just a few seconds.
Excellent. Well, thank you, Paris. So this is our last question of the evening. Let's try to finish strong. I see a lot of you are on the right track already in the question box with your thoughts. Once again, next week's topic is neurology. That's not neuropath or neuropharm or neuroanatomy, just neurology in general. So make sure you read up on neurology before you attend next week's question lab at 8 p.m. Eastern time. All right, I see the responses coming in. We'll give all of you a few more moments. And let's take a look and see what you selected. It looks like in first place was D, coarctation of the aorta by a long shot, and second place was bicuspid aortic valve. Let's take a look and see what the correct answer is. And the correct answer is C, bicuspid aortic valve, and 34% of you got it right. Once again, another challenging question. All right, let's go ahead and hand it off to Paris so we can explain this to us so we can get it right on test day. Paris.
Great, thank you, Sean. Yes, definitely another tough question here. So some nice cardiac path questions today. So this patient has a systolic murmur, okay? Typical of aortic stenosis, okay? So, you know, we're also told that she has chest pain chest pain when climbing stairs or with exertion, okay? So the coronary arteries, when there is AV stenosis or aortic valve stenosis, the coronary arteries actually receive less blood, okay? Why is that? Well, the coronary arteries emerge from the aorta just distal to the aortic valve. So if there's aortic valve stenosis, there's not going to be a lot of blood making it distally to those coronary arteries, okay? Now, they also tell us that this patient has infertility, has short stature, low set ears. So hopefully you guys were picking up that this patient likely has Turner syndrome, okay? It's a genetic condition where the female has a missing or damaged X chromosome, so they're 45X0, okay? In addition to the physical exam findings, Turner syndrome can present with a few different things. Webbed neck, failure of ovarian development, infertility like our patient. So it's important to keep all those in mind, okay? Now, in patients with Turner syndrome, cardiac abnormalities are common, okay? Including bicuspid valve and even aortic coarctation, okay? Bicuspid valve is the second most common cause of aortic stenosis, okay? The number one cause of aortic stenosis is calcification in the elderly, okay? However, in this patient, the more likely cause is Turner syndrome, bicuspid aortic valve leading to aortic stenosis. So step number one, figuring out that this patient has probably both Turner syndrome and aortic stenosis, and then putting that together to figure out, well, it's probably that she has a bicuspid valve that then she had aortic stenosis. So let's go ahead to the next slide, and Sean has gone ahead and pulled up a table looking at Turner syndrome. And you can see there that short stature and some other findings that our patient had as well, but that you can often have bicuspid aortic valve. Now you can also have coarctation of the aorta, but again, we determined that this patient had aortic valve stenosis, so that would be a better answer choice, okay? So let's go ahead and take a look at those answer choices and why some of them may be incorrect. Answer choice E, narrowed coronary arteries. You know, if you were to have that, which would be, you know, what we call coronary artery disease, you can have chest pain, but it wouldn't explain the murmur and it wouldn't explain her other physical exam findings. And it would probably be maybe a little bit later on in life, okay? Answer choice D, coarctation of the aorta. Now, we already said this can be a complication of Turner syndrome, okay? But again, the physical exam findings would be different. We would have elevated blood pressure. We would have pressure differences between the upper extremity and the lower extremity. And we don't really have that. And that wouldn't explain the aortic stenosis as well, okay? Answer choice B, AV septal defect. This is something you can see more so with Down syndrome. So I think that's probably how they were trying to throw you off there, okay? This condition is not associated commonly with what our patient has. And then lastly, answer choice A, rocker bottom feet. This is also getting at a different congenital disease as well. And one other thing to keep in mind is that in mitral regurgitation, you can have, that can be due to a few things. So that can be due to papillary muscle rupture, okay? What we were told is that this was a mid-systolic blowing murmur, and specifically at the right upper sternal border. So this is more indicative of aortic stenosis and not any other congenital disorder outside of what we were told with Turner syndrome. So the best answer here is probably answer choice C, picking up on those additional clues that we talked about. So great job overall today, guys. I know we had some tough questions, but hopefully you guys were able to learn from this session, and I'll pass it back to you, Sean.